Hi everyone. My focus topic presentation is on postpartum hemorrhage. Postpartum hemorrhage is the leading cause of maternal mortality worldwide. Definitions are continuously being revised. Currently, it is defined as cumulative blood loss greater than or equal to 1,000 milliliters of bleeding associated with signs and symptoms of hypovolemia, regardless of the type of birth. Postpartum hemorrhage is classified as either early or late. Early occurs within 24 hours of birth, and late occurs more than 24 hours, but less than 6 weeks after birth. This medical emergency can occur with very few warning signs. Hence, early recognition, preparation, and appropriate management are critical. Nurses have a critical role in monitoring patients because diagnosis is often based on subjective observations, and blood loss is often underestimated by as much as 50%. To summarize the pathophysiology, the 4 leading causes of postpartum hemorrhage can be remembered as the 4 T's. Tone, or uterine atony. Tissue refers to retained placenta. Trauma, such as laceration of the genital tract. And thrombin, or coagulation disorders. There are many other possible risk factors and causes of postpartum hemorrhage, including hematomas, inversion of the uterus, and subinvolution of the uterus. The list goes on, but for now I will focus on these 4 as the most common causes. The leading cause of early postpartum hemorrhage is uterine atony, which is a lack of uterine contraction. A woman is at greatest risk for this to occur in the first hour following birth. After the expulsion of the placenta, the uterus contracts to control bleeding. A lack of contraction, however, results in a flaccid uterus and rapid blood loss. Another cause of hemorrhage is a retained placenta. If the placenta has not been expelled within 30 minutes after the birth, the physician or midwife will need to manually remove the placenta by detaching the placenta from the uterine wall. Manual removal increases risk for postpartum hemorrhage and infection. Additionally, in a spontaneous separation of the placenta from the uterus, there's a possibility that fragments of the placenta will remain. Excess bleeding will result in the uterus feeling soft due to uterine atony. This too may require manual removal of the fragments. Placental tissue can also be retained in the uterus due to an abnormal, implanted, or invasive placenta. This condition is known as placental accrete syndrome. This syndrome can be diagnosed using ultrasound prior to birth, but is typically not recognized until there is excessive bleeding after birth. This is a very serious complication, and treatment is extensive. Lacerations of the genital tract, including the cervix, vagina, and perineum, during delivery can also be a cause of postpartum hemorrhage. Laceration-related hemorrhage should be suspected if bleeding occurs despite a firm contracted fundus. This bleeding can be slow or it can occur as complete hemorrhage. Lacerations of the perineum, illustrated in this image, are the most common of all genital tract injuries. Dark red blood indicates venous origin or superficial lacerations of the birth canal, whereas bright red blood is indicative of arterial blood and can indicate deeper lacerations of the cervix that may not be visible upon immediate examination. When excessive bleeding continues without an identifiable source, underlying coagulation abnormalities could be a potential cause. The woman's coagulation status must be assessed through laboratory testing. Abnormal results may include increased prothrombin time, increased partial thromboplasmin time, decreased platelet counts, and decreased fibrinogen levels, and prolonged bleeding time. Care of women experiencing postpartum hemorrhage requires collaboration of the entire healthcare team. Management includes both medical or surgical interventions. When there appears to be excessive blood loss, the first and primary intervention is to evaluate contractility of the uterus. If the uterus is not firm and defined, management is directed towards increasing contractility. This includes firm massage of the fundus, release of any clots, eliminating bladder distension, and pharmacological interventions, including IV fluid replacement and oxytocin. These are the primary interventions, and if ineffective, other uterotonic medications such as Cytotoc can be given to promote uterine contraction. Alternate drugs to manage postpartum hemorrhage are listed in this chart, which can be found in the Loudermilk textbook. Additionally, blood products may be administered to restore blood volume, oxygen may be administered, and CBCs are typically ordered. If bleeding continues, bimanual compression may be performed as illustrated in this image. The provider inserts their fist into the vagina and applies pressure against the uterus while massaging the uterus from the external abdomen with the other hand. If this intervention is ineffective, manual exploration of the uterus is required. So when the uterus is firmly contracted, yet bleeding is still occurring, the source of bleeding must be identified and directly addressed. Treatment depends on the source of the bleeding. To preserve the uterus, the use of a uterine tamponade is highly effective. Similar to the balloon of a Foley catheter, a uterine tamponade consists of a silicone balloon that is inflated to contour the uterine wall and puts pressure on the bleeding inside the uterus. More invasive surgical procedures may be required if previous mentioned interventions are ineffective. This includes uterine artery ligation, arterial embolization, and uterine compression suturing. If these surgical treatment measures are still ineffective, hysterectomy may be required. The most serious risk of postpartum hemorrhage that is uncontrolled is hemorrhagic hypovolemic shock in which blood flow to the body organs is compromised. Hence, it is vital for the birthing institutions to have protocol and emergency team members prepared for postpartum hemorrhage. Going forward, learning about the dangers of postpartum hemorrhage will shape the care I provide as a future nurse, for I will be highly aware of the signs and symptoms in my patients. When a patient is admitted to the birthing unit, it is critical that the nurse recognizes risk early on. I will assess for complications, specifically the 4 T's. Being educated on the pathophysiology and purpose of interventions, I will be equipped to educate and inform the anxious patient in the midst of the medical emergency. Thank you for watching.